think we'll move on to the second session, which is a very interesting and challenging part in spine surgery. That is proximal junction failure and adjacent segment disease, prevention and treatment. So I'd like to invite the moderators, Dr. Amol Rigi, Dr. Shivakumar, Dr. Neeraj Vasavda, to moderate this session. And the panelists will be Dr. Mihir Bapat, Dr. Ram Chadha, Dr. Rajesh Parasnis, Dr. Jwalant Mehta, and Dr. Q Jung Ho. I would like to inform that the first three cases and case commentary will be live and the lectures will be recorded once. So I would like to invite the moderators to start the session. Thank you.
Yeah, thank you. Thank you, Sudeep. And on behalf of the moderators, Dr. Amul Rege and Neeraj Vasudeva, myself, Dr. Shivakumar, we would like to extend our thanks to the Executive Committee and the Organizing Committee. And let us proceed with the session. I think we have started on the right time. 1 minute. Yeah. Let us proceed with the session. And this session is a very interesting session because it focuses more on the evaluation and management of the fixation of surgical fixation of the spine, failed fixation of the spine. So we will proceed with the case 1, proximal failure after compression fractures, which will be followed by the case commentary by Dr. Mihir Babat. Proximal failure after fixation of OVCF by Dr. Vikas Tandon. And I have gone through the monogram, ASSI monogram, where he has already shown the interest on these fractures. Over to Dr. Vikas Tandon.
Thank you so much, sir. I'm just sharing my screen.
Please.
Okay, thank you so much. So good morning to all of the panelists and the moderators and the chairperson of the session. I have to present this case on proximal junctional failure after fixation for OVCF, that is osteoporotic vertebral compression fracture. So let me start with the case. The case is of a 70-year-old lady. She was previously had undergone surgical treatment for osteoporotic fracture of L4. She had a DEXA scan T-score of -4 in the lumbosacral spine. She again presented to us 7 months post-surgery with a failure. So I will be showing the X-rays to you with a VAS score for back of 8. Throughout the first and the second surgery, she has been neurologically intact and bowel bladder was normal. She had comorbidities like diabetes, hypertension, hypothyroidism, and she was on treatment for rheumatoid arthritis. And there was history of steroid treatment for rheumatoid arthritis. And since the first surgery, she was put on anti-osteoporotic treatment in the form of teriparatide. We had also done all the tumor markers for ruling out the multiple myeloma and other pathologies, which were all normal. So here on your screen, you see the first set of X-rays when she presented for the first time. There was a fracture of L4. You see the AP and the lateral views. And you also see the flexion and extension dynamic views for the lumbosacral spine in the lateral views. This is the sagittal and the coronal and sagittal and the MRI picture of the patient. You see there's a fracture of L4 and other healed old fractures above. So, okay, let me ask the panel, how would they do this case first of all, so as to just to start a discussion. Anybody would take the case? How would they go ahead with this case now? Any takers, or should I go ahead?
Because she had any neurological deficit or only pain?
Only pain in the back.
Yeah. In that case, I would just do a vertebroplasty and minimal internal fixation.
Vertebroplasty and minimal internal fixation. Okay.
Vikas, how long did she have the pain for?
She had it for almost about 3 months when she presented for the first time, sir.
And because obviously you will treat the osteoporosis aggressively.
Yes.
So with a DEXA of, was it T score or Z score of -4?
T score of -4.
Okay. I think with a T score of -4, I would do nothing right now. I would just treat her aggressively for her osteoporosis,
Okay.
not fix her, um, and then review after
Okay.
a few months.
Okay. So we have two options. One is doing nothing, only treating osteoporosis. And the other option is treating osteoporosis along with minimal fixation and vertebroplasty. Any other options do we have?
Go with vertebroplasty with one above and one below, sir. Minimal invasive fixation.
Minimal invasive, MIS. Perfect. Perfect. So this was done for the lady. In fact, I did the patient. I did the case. I was more aggressive, and I did this all posterior. I did one level up and one level down. That is fixation in L3 and L5 with cement augmentation. And I thought that the combination of the fracture was really bad. There was so much combination that cement or vertebroplasty won't hold there because it was a comminuted fracture. So I thought of doing a corpectomy. I did all this from posterior and did and put in an expandable cage, which I thought I would be able to manage and negotiate through the roots. So this was done. So any critical comments on that? I understand this is a little bit more aggressive, but yes, any comments on that?
Because I should really congratulate you from doing all that posterior, because getting that cage absolutely perfect from posterior requires a master skill like you. It's very difficult, I think.
Thank you so much. Probably, I would agree with the first option of putting doing vertebroplasty, but to my understanding, I thought it was too comminuted and the cement won't hold there. So I opted to go in for a corpectomy and I did this. Any other comment from the panel, please?
L1 is compressed. Is that a new or is it old compression fracture? L1. L1 and
That
probably
is an old fracture, sir.
L as well.
If
Old fracture. Okay.
if you see this MRI, you see that is a failed fracture there, sir.
Okay.
The fresh one was the L4 one.
Yeah.
Because one more comment is that you should rule out always multiple myeloma when there are multiple fractures, which I'm sure you must have done.
We have already done that. I mentioned that. We did all the tumor markers for multiple myeloma. It was negative.
In most cases, I try to put the screws at the fracture site. So in this case, I will insert the screws at L4 because it lead to obtain more purchase and get more stability.
Okay, got it.
I would disagree with that. I don't think you'll have any hole in that L4 screw with such a osteoporotic fracture. You can see almost edema in the whole bone. So I think a vertebroplasty is a sensible option rather than putting a screw in L4.
So Amol, what we started doing now is, minimal invasive. We put one screw above, one screw below. We put one screw, the cannulated screw percutaneously into the fractured screw, and we inject cement through the screw. So that whole part, is taken care of, and we are quite satisfied with that. It gives stability. Patients are also mobile very early, and maybe, I think that has.
I think you're trying to put the principles of traumatic fractures.
Yes, correct.
Bones. But I don't think it'll really work in such. That is my.
Yeah, but I think, the whole part, that gives more stability, and you can, in fact, get away with a short segment fixation in a very severely osteoporotic spine.
Okay.
Am I allowed to have a question for the panelist here? I'm
Sure.
Dr. Pankaj here.
Sure, Pankaj.
Yeah. So is kyphoplasty or vertebroplasty alone an option here when the patient only has pain, no instability catch, I guess?
No, can I?
Yeah, please go ahead.
Yeah. So I think what we need to understand here is that the whole attempt is just to control the pain. So vertebroplasty is basically to have control on the intravertebral instability. And what you need to sort of augment it on a temporary basis. Because if you do a short segment fixation in an osteoporotic bone, whether you do it percutaneous or whether you do it open, that fixation is going to loosen over a period of time. And you have to keep an open mind that the screws may have to be extracted once there is a sufficient stability, which is sort of achieved inside the index vertebra. that segmental fixation usually doesn't stand the test of time in such severely osteoporotic bone.
No, I think my question was whether kyphoplasty alone was an option here.
Yes, it was definitely an option.
May I interject here, please?
Yes, Dr. Ram.
See,
Yes.
let me be very frank, and we orthopedic spine surgeons need to understand there are two different words in English. One is called options and the other is choice. Options are you can do anything. Okay, choice is what is the correct way of doing it. And as far as osteoporosis is concerned, it's not just less is more, least is most. And biology works against us. So please remember that if pain can be controlled without intervention with medication, as mentioned by Jwalant, that should be the first option and probably the right choice.
And also, if I can just expand on that, I think with a T-score of -4, I think it's a systemic disease. It's not just L4. There are other levels. I mean, I won't be surprised if there were some changes in L3 as well, and I won't be surprised if these screws pull out. You do short segment, long segment, any segment. You got to just treat the patient rather than L4. Unless you have a, affinity for L4, the patient is more important.
Absolutely, I totally agree with you. Sometimes you do make wrong, choices and wrong decisions. But so I had to show this case. I am there with you. So 7 months down the line, she presented again. I mean, after this first surgery, for a short brief period of time, she was mobilized. She was walking, and she was pretty okay. She was happy. She was on anti-osteoporotic treatment, and she was mobilized. But 7th month post-op, she presented with this. And she again had very severe pain in the back, and still neurologically intact, couldn't stand because of the pain. So this was the X-ray picture. You can see the screws are cutting out above and hitting the upper body. We got the this is the standing supine picture only because she had so much pain that we couldn't make her stand. So this happened. There was cutting of the implant.
Dr. Balavenkat, one of the speakers in your
picture of
session, he has joined in, but he wants to become a panelist. On that, can you just
upper vertebra, that is the L2 fracture, L2 vertebra also fractured. So how do we address this now? And what are the things that we also need to discuss what was the reason for the failure. So the question is open to the moderators, the panelists for this. How do we proceed now, and what are the reasons for the failure?
Because I believe the patient is on teriparatide.
Yes, the patient is on teriparatide.
Thank you.
Yeah, so I think because right from the beginning we were sort of dealing with a malignant form of osteoporosis. It's not a simple form of osteoporosis. It's going to be progressive. Second is that segmental fixations in the lumbar spine in an osteoporotic bone is in itself a mechanically unstable situation. Thirdly is that if you see the rods, they are hyper contoured. You have tried to correct the lumbar lordosis a little too much. That has actually put a lot of recoil force on your cage. So apparently with a stiff rod, either the screws had to migrate or the cage had to sink. Now, ultimately, both of these things happened. And subsequently, the adjacent vertebra also collapsed.
Yeah, I totally agree with you. The reason for short segment initially was that because you want to save the levels in the lumbar spine. That was a thought process behind it. But I agree to your points. The rod was badly contoured. So all bad things happened. It added to one added to the other, and all this happened. And we have this situation now. How would you like to go ahead with this now? How do you plan to go ahead? Should we do something now? Obviously, we're in a soup now. What do we do now?
Vikas, can I ask you what's happening with the left proximal humerus? When was that fixed?
That was a long time back, sir.
It's well healed.
that was done outside and some years back, sir. Should I show you the other closer picture? Yeah.
Sir, if you don't mind, we are slightly running out of time. I think you can proceed.
Okay, I'll just proceed then. So this was the picture that we saw, and I did not attempt to remove the cage. And I went ahead and did multiple fixations with cement augmentation. I went till T10, and I also went down to have better fixation and put in Ailer screws, S2 Ailer screws. And I also did vertebroplasty above at the adjacent levels to prevent further PJK. I changed the screws that were cut out and I put in a larger diameter screws there just to get a better hold in the cutout place only. So this is what I did, and this is the final picture. As of now, it has been about 6 months down the line. Patient is going on. No complaints as yet. She's walking, but I expect her to come back. This is the picture, the whole spine picture. But this is again supine. This was taken only at the time of the second surgery. I don't have with me the current X-ray when she's standing, but she is walking as of now.
Dr. Megan?
Any comment?
Yeah, so Vikas, I think we had already committed ourselves to a second surgery because that was quite unavoidable. I think because you had a proximal fracture at L1, you needed to go up into the dorsal spine, and you have fixed at the correct levels. That means from D10 down to S2.
Yeah.
So that is the level of fixation. The only thing is, how do we decide how much to correct when you have a proximal junction kyphosis? It is always better that you do not overcorrect. You keep back a little bit of kyphosis, which the patient can use for their function. These are elderly patients who need to stoop a little bit for and you need to give that kyphosis to them. If you overcorrect, you are actually predisposing them to the next fracture because that's going to happen when they stoop forwards. So regarding the vertebroplasty,
were you able to get it?
Regarding the vertebroplasty at the
No
proximal
problem,
level,
but there'll be questions for you.
the vertebroplasty per se is highly controversial. That means that some people believe that it protects, some people believe that it actually predisposes to an adjacent segment disease or an adjacent segment fracture. Another thing about cement augmentation, a little thing which I want to point out is that whenever you use these fenestration screws with a cement, be very careful of an epidural leak.
It happened there.
Yeah, so if you see the second screw from the top,
yeah,
there is an epidural leak, and these chances are quite high when you use fenestration screws. But overall, at the time being, this looks like a very good fixation. I hope you have done a very, very meticulous fusion in the operated area. And let's hope, because the proximal junction problems can occur as late as 2 years, 3 years, 4 years down the line. So you need to keep a close watch on this.
I get your point. And if you look at the fenestrated screw, this is the only time when I use fenestrated screws. I usually don't use fenestrated screws. I usually put my cement there and put in a solid screw over it. So this was the last time when I used it, and this was the first time when I used it. Actually, it's very difficult to, first of all, inject cement in the fenestrated screws. It's so difficult to push in the cement there. Secondly, you don't have any control on the cement when you're pushing it through the screw. Luckily, there was a epidural leak which was asymptomatic, so we were lucky in that. And regarding the adjacent level vertebroplasty, there have been multiple biomechanical studies which have been done, so that if you put it above upper 3 levels in a reducing manner, so as to give a soft landing sort of a thing, it works. That's what we all believe at ISIC, and that's what we do over here. So this is what is our thought process. Any other further comment? Then we move ahead with commentary of Dr. Mihir Bapat after this.
Because medically now, are you combining teriparatide and denosumab just for the medical part?
So this time I added denosumab as well.
Okay, thank you.
Because where did you get grafts from for such a big fusion?
So the spinous processes.
Gentlemen, we are about 7 minutes late. I believe that, Mihir, do you have a separate case commentary, or is this all?
I think we have covered most of the.
Right. So then let us move on to the next presentation.
Yeah. Okay. So let us invite Dr. Thomas Kishan for presenting his case on adjacent segment disease after instrumented lumbar fusion. Over to Thomas.
Good morning, everybody. My topic is adjacent segment degeneration after instrumented lumbar fusion. And I'm going to present this case, which I borrowed from a colleague of mine. So 59-year-old gentleman was a bank employee nearing retirement. No medical comorbidities, no diabetes, hypertension, otherwise well and healthy. Presented with severe back pain and bilateral calf pain, posterior calf pain of 3 months duration. He was unable to stand or walk for more than 5 minutes. Turning in bed was also painful, and going from sit to stand was very painful. There was no fever or constitutional symptoms. His lower limb neurology was normal, so was his bladder bowel. Blood counts were normal, although the ESR was mildly elevated, and so was the CRP. Okay, so that was his MRI. And I'll just go through his pre-op investigations, and then I'll come back to the panel for your comments. So that was the MRI, shows some signal changes around the L4-5 disc on T1. And that was the X-ray. So L4-5, there seems to be some irregularity of the disc space, narrowing of the disc space, some anterior traction spurs / osteophytes. So, and this was what was done. Okay, so during surgery, the disc was curated, sent for culture, histopathology, and gene expert, all of which turned out negative. In consultation with the ID physicians, an 8-week course of antibiotics was administered because there was a doubt of an infection on the MRI scans. Over a period of time, the blood parameters returned to normal, symptoms subsided, and the patient returned to work. Okay, now I go back to the X-ray and the MRI, and can I ask the panelists, Dr. Mihir Bapat, probably, anything that concerns you? Would you do anything differently?
Actually, no. The thing is, it looks suspicious of an infection because there is anterior
Yes.
paravertebral mass. It could be disc or it could be infection.
Yes.
And you have ruled that out. I think you have followed the correct strategy here.
Yeah. No, surgically, would you do anything different? Yes, Dr. Amol Rege.
One comment is that you need a gadolinium contrast MRI before you do anything.
Okay. Sure.
Second comment is you need to have a tissue biopsy before you do any surgery for this patient.
Yeah, but he was severely symptomatic with bilateral leg pain.
Yeah, but
there was stenosis at 4-5.
That does not prevent you from doing a biopsy.
Okay, fair. Surgically, would you do anything different? So imagine that all this was, sorted out, and then you thought it was an infection, or did not think it was an infection, and then went in for surgery. Any thoughts on the surgery itself? Would you do anything differently? Would you go down to the pelvis, or would you stick to one level?
I would stick to one level. I would try to stick to one level.
Thomas, one interesting observation, which if you look at your preoperative AP X-rays, it doesn't show much of the curve. But if you see your post-operative AP X-rays, actually 3-4, seems to be an apex of a lumbar curve. So this curve came.
So see, in this X-ray, the wedging of the disc is at 4-5 in the pre-op, and there is a pelvic tilt also. So I know it's just a lumbar spine X-ray. We don't have the full spine. We don't know whether it's standing or not. But that tilt of the L5, the pelvis is definitely tilted. And as a result, is it a suprapelvic cause because of the wedging of the disc, or some infrapelvic cause because of limb length discrepancy?
Can I? Because see, the rotation of these vertebrae is not significant.
Yes.
If the patient is very, very symptomatic, then there's an element of severe muscle spasm, which causes a little bit of list. Now, this is not a significant degenerative scoliosis.
It is not.
That can be attributed to anything that can happen later.
Okay. So can I, from the panelists, would you do anything differently? So what was done for this was an L4 to S1. I think Dr. Mihir Bapat said you'd just stick to one level. Neeraj, what do you think?
I will also stick
Would
to
you go
one
down
level.
to the pelvis? Or
No, I'll stick to one level.
what is your thinking on this? Why wouldn't you go down to the pelvis?
Well, I guess, I mean, the only symptomatic level seems to be 4-5, not the inferior level. At the most, I might add one foraminotomy on alpha S1 because, probably if patient is having S1 radiculopathy, I mean, clinical parameter is if it confirms, maybe I'll add just foraminotomy at alpha S1, but not the fusion at alpha S1.
Dr. Cho?
Yes.
Dr. Cho, can I have your thoughts? Dr. Cho, would you do anything different for something like this?
Yeah, if this is my case, I will do surgery at 4-5 only, and I do not insert the cases because it may cause delayed treatment of infections. So,
okay.
So just the posterior instrumentation and decompression is my option.
So would you do a interbody fusion and with bone graft only? No bone. No, but we
no
some
bone.
disc
Yes,
infection.
just decompression. Yeah.
Okay.
So sorry to be a sore thumb, but what I'm going to suggest something slightly different.
Sure.
Firstly, I think what Amol said is really important. We've got to think of all the conservative options. We've got to do all the percutaneous options before we go in.
No. Sorry.
Now,
this is adjacent leg bend. So we are just
Yeah. So the other thing
assuming that all that was done.
I was of the opinion that we should, if it's a suspected infection, go in from the front, not use a cage, but use a iliac crest as a graft. Because if you're treating infection, you're treating infection. If you want to use a cage, that's fine. You want to jack out the disc spaces just a little bit. If there is some foraminal narrowing, it wasn't huge amount. There was some, but if there was, you can easily deal with that from the front, and you can get a good fusion from the front. And then you don't have to talk about pelvis, talk about scoliosis. All that is not required. He, by the sound of it, is 59, otherwise fit in well. So I think
yes.
Yeah. I think that should be enough for him.
Sure. Thank you. I'll just go on just because we've got more floor to cover. So post-op X-ray still shows the pelvic tilt, and there is a wedging of the disc above. So that's 3-4. So he did well. He did well for 3 years. The infection or whatever it was subsided. Well, got back to the workforce. Retired at around 60, and then came back in 2009 with these complaints. So worsening back pain, bilateral anterior posterior thigh pain of 6 months duration, standing and walking significantly restricted. There was difficulty in going from sit to stand. So getting up from a sitting position. He was unable to bend forward, and he wasn't able to go below the knees. A whole range of non-operative treatments were tried, including medications, physiotherapy, facet injections for at least 4 or 5 months, and there was no relief. This is what his X-ray looked like. So this is 3 years post the index surgery. Any thoughts, Dr. Rege?
I mean, there's an adjacent segment failure, which is really difficult to explain, considering that it was a short segment fixation. So, I mean, I would like
worried about this pelvis being tilted. Do you think that could, put the
Have you looked at the leg lengths?
Yeah, I don't know. I mean, all X-rays show the same thing.
No, CT scanogram to look at the leg lengths
would be a good option. Yes.
Does the patient have any? So now the position you are in now, I don't think thinking of more levels is the way forward. Before you do anything else to him, you've got to really look at everything with a fine-tooth comb. You've got to look at full spine X-rays, lower limbs, hips, see how he's standing, whether he's crouching or not, whether you're really having a deformity or is it just that 3-4. What you don't want to do is do a 3-4 and then a bit more, then go up to T10, then go up to T2. It's a never-ending story. So I think you've got to stop now. Think it through really well before you touch him.
So you would advise a full spine standing X-ray to just look at what's happening.
I would have done it much before. Yeah, definitely.
Anything else?
Thomas, have you noticed that there's a lucency around those additional screws that you put lower down in the sacrum?
Yes, I think so. Yes, but that was there only on one of the views. On X-rays taken later on, they were not there. So I'm not going to pay too much attention to that.
For the time being. So we need to rush.
Yes. Sorry. Yes. So eventually the patient had the second surgery, which was in December, 3 years after the first surgery. which was an extension of fusion to L3, which Dr. Mehta said we should not probably do. And yeah, when, as luck would have it, significant relief of back pain, improvement in his ADLs, able to walk around, and he was quite happy. What do you think? Dr. Mehta, what do you think?
We still don't have the full spine X-rays.
We don't have the full spine, but if you look at the X-ray, the pelvis is still tilted.
When are you going to extend him to? When are you going to do a CT scanogram of the lower limbs?
Yes,
look at the rest of it.
Yes. So
And
that was his X-ray. That was the X-ray, full spine X-ray.
What's the pelvic incidence?
Pelvic incidence 50.
Thomas, now it is 2-3, which is probably showing eccentric collapse. Initially, it was 3-4.
No, this
2,
is
3.
post the second surgery. This was when he was doing quite well, actually.
Okay.
So
give him a heel raise, he'll be fine.
Heel raise, he'll be fine.
Thomas, we really need to wind this up because we are overshooting.
Sure. So yeah, that was the pelvic tilt that we saw. That was the anterior sagittal imbalance that we saw. That was this pelvic incidence, and that was his lumbar lordosis. So there was a significant variation between lumbar lordosis and pelvic incidence, and this was 2009. And he came back the next year with severe pain again, back pain, bilateral anterior thigh pain, unable to walk unassisted. Neurology was normal, fortunately, and that was his X-ray in 2020. So top screws have pulled out, and the cage that was put in during the second surgery has actually subsided. Any thoughts? Dr. Cho?
Yes.
Dr. Cho?
Yes. I think extension to L3 is good choice at that time. But after 1 year after last year, the cage subsidence occurred. So that's the problem is the
aggressive curettage of the end plates or something, you think? Or?
Yeah, I think that the manipulation of end plate during LF is the problem.
So what would you do now? What would you do now? So this is his condition, significant restriction of ADLs. We need to do something.
You have to extend the fusion to above T9, T10.
T10? Not worried about the lumbar curve at all?
Yeah, you can think the extend the fusion to L1,
just extend
T12.
it upwards, you think? Sorry? Dr. Amul Rege, what do you think, sir?
I think we are short of time. So further, we can ask Dr. Ram to.
Sure. So this was his X-ray in 2020. So this is with the pull-out. And yeah, pelvic incidence, lumbar lordosis, the same. That was his MRI done at that time. Showed a bit of stenosis at the level above. That was the CT scan done at that time. So the first interbody fusion had healed up. The second one, there was subsidence of the cage and non-union. And this was what was done eventually. So extension of fusion, Dr. Cho, as you advised. So now we've gone up to what, T10 or T11?
Yes.
Can we ask Dr. Ram for the commentary now?
Yes.
Thank you very much, guys. Okay. Thank you, Amol. Thank you, Thomas, for an excellent case.
Thank you, sir.
Well, I'm in short going to just speak about adjacent segment disease, what I have learned from my experience and the little literature that I have gone through. 1, 2, and 3. This is the way I look at it. 1, whenever we do any spine surgery, especially in the lower back, the primary surgery, whether it is of decomp alone or decomp with stabilization, should be limited to the minimum, either by choice or accidental invasion onto an adjacent level during the primary surgery makes it more common for you to have an adjacent segment disease in future. Even checking a wrong level, more common in the cervical, but even in the lumbar level, checking a wrong level without being overconfident or being overconfident can precipitate a crisis. So that's 1. So please remember, restrict yourself to the least invasive. Now coming to 2. Most adjacent segment diseases are supraadjacent. However, subjacent also occurs. What I mean by subjacent, is L4-5 whenever you are either instrumenting, fusing, or even at times just doing an uninstrumented fusion. You can get an L5S1 or a sacroiliac adjacent segment disease. So subjacent also happens, though supraadjacent is far more common. And finally, number 3, which is 3 points. Look for adjacent segment at 3 areas and evaluate the biology and mechanics of each. First, just a disc herniation. So this is either, as I said, inadvertent or excessive mechanical loading or biology of the disc worsening, normal natural progression of aging at the next level. So there may be just a disc herniation. Next is disc plus instability, which means you've handled or loosened the facets or you've not respected the sagittal curvature well. Incidence was not respected. Hence, you may develop a disc with an instability or an instability with or without a disc at the supraadjacent, like a listhesis. And third, also look for it every time as we deal with the aging population, an intracorporeal adjacent segment disease. You may develop an intracorporeal bony collapse with age. So you may have an supraadjacent just disc herniation, supraadjacent disc herniation with instability, or a combination of these with a collapse or an osteoporotic vertebral compression. So keep your minds open for all 3. The way forward, as I said, is minimalism. Least is most. That's all that I would like to say. Thank you so much.
Thanks, Ram, for excellent summary of the 3 mantras. Now I invite Dr. Ranjit Unnikrishnan, who will present the case on PGF after correction of adult spinal deformity.
Correct. Okay. So with this, let us go to this. It is a proximal junctional failure after adult spinal deformity. Thanks to Dr. Mike Kelly, my fellowship guide at the WashU, to lend this case for me to discuss. So this was a 52-year-old lady with history of multiple prior lumbar surgeries who presented with significant thoracic pain and a complaint of forward stoop in the sagittal spine and difficulty, significant radial affection, and was wanting to do something. Let me ask Dr. Mehta, Dr. Jalan Mehta, what would be your take on this particular case?
So she's had multiple prior surgeries. I'd like to know what her parameters are. I can see that she's standing, the hips are not particularly flexed. She's probably a bit of flexion at the knees. Maybe she's crouching a bit. And
she had both of her knees replaced.
Okay, no, that's fine. I'm just looking at her overall alignment looks fine. What's the problem? What is she presenting with?
Significant thoracic pain affecting her ADL.
So have you got a scan of the MR of the full spine? Does she have any other medical factors?
Nothing in the lumbar canal other than a lot of canal encroaching with the hardware. And she has got minimal stenosis. More of it is axial back pain.
No. What I mean is, have you got an MR of the full spine with stirs to look at whether or not there's any?
Yes. Infection has been ruled out. There is no significant canal stenosis anywhere else other than
osteoporosis.
Yes, she's been free. She was on Prolia then. Was Prolia for this?
Has she had any other physiotherapy and other treatments?
All sorts of stuff has been done.
So I would also do a CT of the instrumented levels to see whether you've got a good fusion there, and probably look at the parameters and see if if there's any malalignment anywhere.
Yeah, so these are the full spine X-rays.
I'm sure if it's Mike Kelly's case, he would have done something more than that. I mean, what's the SVA like? What's the pelvic tilt?
So she's off balance in the front. He did give her pain blocks, pain blocks. So these surgeries were done elsewhere, was referred to WashU. So Mike did multiple road blocks and even advised her pain pump because she was using axial pain, which she refused a pain pump. And she was wanting to do something.
Is this a tether or is it
Yes, it was. Yeah, she had airlift free sittings with a upper tether and lower fusion levels.
So we need to know what's happening with the movements there. I mean, it's not one of the operations that we would consider fairly middle ground.
Okay, so for instance, in interest of time, I would go ahead. So this is what Mike did for him, did for her then, when they had done an extension to T3 with PCOs at the thoracal lumbar junction, and this was the post-op X-ray. So at this juncture, I would like to ask Dr. Mihir Bapat, what is your take on this at this point of time, sir? You think she's done, or there's more to the story?
The thing is, like Jwalant, I agree. I seriously did not know what the pain generator was. So extending up to D3 was probably not my option. And if the patient is happy at the end of it, it's fine. But I don't think it's the end of her problems, for sure.
Why do you think this is not the end of a problem, sir?
Because fusion is never an end of the problem. It is always aimed to control one complication. And if you're not sure of your pain generator, fusion will never solve the problem. So I think just getting the whole spine fixed will just add more stresses onto the cervicothoracic junction. And she's going to use that more and more. So the pain would shift from the mid back to the upper back.
Interestingly, she was very much happy, pain-free after this procedure, who had gone back to all her regular activities. But she came on 3 years post-op. She reported of difficulty in walking, and one fine day landed in the ER with paraplegia. So this was the X-ray at this point of time. Dr. Ram, what would be your solution at this point of time, sir, for this?
Well, obviously, I need an MRI at this time to find what's happened. Is it a combination of an osteoporotic vertebral compression fracture? Is it a dislocation as you're showing it now? So I need to find out a cause. And once I find out the cause, I obviously have to believe that that is the only cause. And if it's recent in duration, and I look at a sensible choice for intervention, I would need to go ahead, like in any other situation, correct the cause, which is remove the compression that I can see on an MR, and then take a call as how I go across the cervicothoracic junction and say my prayers and tell her to join me in the prayers.
So this is exactly what was done. So it was extended because it was proximal degeneration with a listhesis, which happened over 3 years. So this was reduced and a single level fusion was done. So we all think everything was done. And 1 year later, she presented with similar complaint, and she had gone back to walking using a cane. So Dr. Neeraj Vasavada, at this point of time, so what do you think has gone wrong? And
I guess, as Dr. Ram said, these are endless stories. How far you go up, how long you go, that is always an enigma. If you see when they went for thoracic, cervical was still toppling off. Before when they went up to D3, D2, the cervical was still, C2 was still off the center. So this was bound to happen. So we really don't know how long we have to go, whether we should go all the way to C2 occiput every time, or we keep on going. That's an enigma. So this is a case where this is adjacent segment degeneration or a PJ case are a never-ending story.
No, I think what I mentioned in the first case is that we assume that the patient is off center, but the patient is actually using that kyphosis for her daily activities. You are trying to correct the kyphosis for her, and she is toppling back into her functional position. So that is what keeps happening. That means the patient needs to stoop for her activities. Whatever she is, her spine cannot compensate for overcorrections. So if you offer too much of rigid overcorrections, it's going to topple back. So that's what keeps happening. So you need to sort of strike a balance. You don't need to correct it.
So Ranjit, I think you need to close because we are running out of time.
Yeah. So this is what was done. It was fixed to C2 with the reduction of spondylolisthesis. So with this, I opened the case to Dr. Rajesh Parasnis. So there were questions which I have to him is, sir, what is going wrong? What exactly is the PJ and why is it happening? Who are the patients who are more prone for it? Does it happen only in adults? Is it an adjacent segment degeneration, or is it something else in play which is causing this? why did it happen even after treating the BMD and all sorts of prophylactic otoplasty, etc.? And does minimally invasive surgery prevent it?
Yes, go ahead.
So going back to what the questions he has raised, PJK is defined as a kyphotic deformity cephalad to the UIV. Now there is a little disparity in the literature. Some people feel more than 10 degrees, the angle between the inferior end plate of the UIV and 2 levels above the upper end plate. But some also believe that up to 15 to 20 degrees is actually PJK. The incidence is between 5 to 46% of all adult spinal deformity fixations, and 66% of this PJK can occur within 3 months and 80% within 18 months, and it just goes on. Now, the PJF is actually an advanced stage in the same spectrum, the progressive process of PJK, and characterized by either a fracture or a subluxation close to the thoracolumbar junction or subluxation higher thoracic. It can also be just a failure of the construct and characterized by the disruption of the posterior osteoligament complex. Now, clinically, this is much more severe, characterized by pain, instability, neurological deficit, and its reflection into the socioeconomic condition of the patient as well. Now, this is actually an ASD radiologically, but much more severe, brought about by the rigidity of the construct and the disparity of the bone strength above, and the junctional stresses are much more than a common normal ASD. The patient-related risk factors which lead to PJK and PJF are low BMD, high BMI, comorbidities, age more than 55, and particularly in female patients. Radiologically, you will see other parameters. The surgical risk factors during surgery is there is an injury to the facets, injury to the posterior tension band. If there is extensive surgery done with osteotomies, anterior and posterior combined approaches with solid fusion, fusion extended to the spinal junction, and all pedicle constructs, no soft landing above, very stiff rods being used. The UIV, if it is closer, lower to D10 or in the lower thoracic, it is supposed to be higher than when you go to D2. Bicortical screws at the UIV and very extensive correction. All these are risk factors surgically. Radiologically, if the SVA change is more than 5 centimeters, if you have very high PI, very low LL, and the extension of the fusion is more than 12 levels, it is extending to the pelvis, all these also are risk factors. Now, there is classification by Buachi et al., but doesn't give much of prognostic information or tell us about what management should be. But this score of International Spine Study Group can give you a certain idea of what the parameters are, whether to go in for PJF. Now, what in this particular case you can clearly see, even though we don't have the parameters precisely, there is a little high PI. The first fusion level was extending to the S1, but proximally only to L1. Probably we don't know about the BMD also. And when the second revision happened, it was a classical spinopelvic fixation with very extensive segmental and not adjusted for age-appropriate sagittal parameters is what we can see. All pedicle screw constructs are known to have high risk of PJF. Now, asymptomatic patients of PJA, you are just supposed to observe. Now, that is what the objection was to person with just thoracic pain. Why should you go in with such an aggressive surgery? These patients will require a little more of awareness, counseling, bracing, close monitoring, and conservative treatment. But when PJF occurs, revision surgery may be required. You may require multiple osteotomies to correct the parameters, but that is the time you have to do something at a proximal end to prevent further PJF again, because the incidence of PJF from 40% goes to 80% when more than 2 surgeries have done. Now, intraoperatively, the soft tissue considerations are extremely important. Maintain the posterior tension band. Don't violate the facets. Either try to use hooks or screws or tapes or something above. Use the biologics to increase the bone strength. You can use the vertebral cement augmentation, but that's controversial. Perioperatively is extremely important to identify the high-risk patients. Age-appropriate, age-assisted sagittal alignment is very, very important. Protect them post-operatively, avoid falls. So these are the various ways you can actually use in the first revision to make sure that the second doesn't occur, but you can never be sure. Thank you.
Thanks, Rajesh, for an excellent summary. I am proud to introduce our next speaker, who is a close friend and a batchmate, Dr. Jwalan Mehta. We were together at GS Medical College, Mumbai. Dr. Jwalan Mehta currently works at Birmingham in UK as a consultant spine surgeon. In the last decade, UK has seen a big revolution, which is called Mehta Spine. And Jwalan is going to tell us all the tips of how to reduce these complications we just saw in the last few cases and the importance of the gap score. Jwalan, all yours.
I'd like to thank the leadership of the ASSI for inviting me for this Assicon. On the virtual platform. My charge is to talk about how to prevent proximal junctional failure in patients with adult spinal deformity, particularly with the importance of the GAP score. These are my disclosures. The modern day spinal deformity surgery has achieved its position by pushing boundaries in various directions. We have better preoperative planning. We have better instrumentation systems, stronger rods, pedicle screw-based constructs, better anesthetic techniques. We risk stratify patients to decide on who's a good candidate for surgery. Despite everything else, we are still plagued with mechanical failures, particularly rod fracture and proximal junctional failures. Proximal junctional failure is really end of the spectrum of proximal junctional kyphosis, where the patients can have a loss of correction, loss of horizontal gaze, but more importantly, pain and a possible neurologic deficit, very often leading to unplanned return to theater, as well as morbidity. There are lots of risk factors relating to proximal junctional failure, which have been discussed in other parts of this session. I will not repeat this, though I'd like to point out that there are some preoperative non-modifiable factors that we should consider rather than try and modify, such as age and a large preoperative deformity. What we can influence, though, is the type of surgery that we perform, particularly with regards large vertical axis shifts created by the operation, large lordosis and kyphosis correction, and particularly a tendency towards overcorrection. At the center of it all is an understanding of the alignment. If you think of an inverted cone as the area in which we stand in a normal resting position, and further consider three subcones, the lowest one representing the pelvis and the lower extremity, the middle one representing the thoracic, lumbar spine and the pelvis, and the upper one representing the head and the neck. This can then help us identify the zone in which we can function optimally with regards to musculoskeletal system. Rusali has identified spinal shapes. This is more in asymptomatic normal individuals and is based on low and high pelvic incidence. He has then gone on to identifying the changes that can happen with aging. With the identical pelvic incidence, there are changes in the lumbar spine, thoracic spine, but also pelvis and the lower extremities with the passage of time. Based on the pathology, particularly with regards to pelvic incidence, we can see here that in the top image, a low pelvic incidence has a much lower width of the pelvis and is much lower than the L5S1 disc. Whereas in a person with a high pelvic incidence, the broadest part of the pelvis in the sagittal view is much higher, virtually at the level of the L5S1 disc. Based on this, he has described 5 subtypes, and he's gone on to have a more composite description of multiple spinal shapes. Studies have showed that when we correspond reconstruction of the spinal shape by surgery, the outcomes are better. This is a study that showed that in a non-restored group, there was a 5-fold increase risk of revision surgery due to mechanical complications. The Schwab classification has identified 3 broad parameters as being useful in identifying what this ideal alignment should be. These are pelvic tilt, this global balance as measured by the SVA, and a PI minus lumbar lordosis. He has then gone on to granulate this information based on age by each passing decade. As we can see in this table, a person who's over 74 years of age clearly needs a lot more residual deformity than someone who is under 35 years of age. In other words, overcorrecting an older patient leads to problems. This has to be borne in mind when treating patients with adult spinal deformity. Parallel to this venture has been the development of the Global Alignment and Proportion Score, or the GAP score. This was designed by a group from Istanbul in Turkey, is based on pelvic incidence and accounts for age. It is a sagittal plane analysis and predicts mechanical complications. And the beauty of this system is that it not just accounts for changes in one plane, but in both the front and the back in the sagittal parameters. Assuming that the human vertical is a normal aligned position, we have a spectrum of malaligned or disproportioned on either side of the normal alignment. This measure is based on 4 parameters. The relative pelvic version is based on the sacral slope and is the equivalent of a pelvic tilt. The ideal sacral slope is obtained from an equation as shown here based on the pelvic incidence. The relative lumbar lordosis is a L1-S1 lordosis. What's more important is a lordosis distribution index. In an ideal setting, L4 to S1 lordosis accounts for 2/3 of the entire lumbar lordosis, as has been shown by work from France in the past. However, when we measure the lumbar lordosis distribution index, it gives us a better idea as to the extent of the pathology we are dealing with. The one big change in this measurement system is the introduction of the global tilt. This has been shown as a new parameter and much more aligned and much more constant with, as regards the other global parameters that have been described in the past. Based on these 4 and the age being either over or under 60 years, a score has been developed. Anyone who's disproportioned will have a score of over 3. Anyone who is severely disproportioned will have a score of over 7, the maximum score being 13. Assuming that we can get our measurements from some software that we are used to, we can plug them into this app that is freely available on the App Store, and we get measures very easily on whether the person has a severely disproportioned or a proportioned spine. All we need to know is pelvic incidence, age, sacral slope, L1-S1 lordosis, L4-S1 lordosis, and a global tilt. The originators of this classification had a very close association between mechanical failures and the disproportion, as we can see in this graph. However, this has not been universally noted in other studies. This study, which is between Denmark and Texas, shows that there was no real association between the postoperative gap scores and mechanical failures for revision. Another study from New York looks at the gap score overestimating mechanical complications after adult deformity corrections, and that there was no statistical significance and there was a very poor generalizability based on the outcome of the study. This is another interesting study that looks at global alignment scores in an asymptomatic non-operative cohort and shows that a proportion of patients that are severely or moderately disproportioned are in fact asymptomatic. This is one of my patients with a high gap score, which where we undertook a good correction of lumbar lordosis. She was fine for about 2 years until she presented with a proximal junctional failure. I had to then reoperate on her at a gap score of 8. This is before the time that gap scores had been described. Although I did not majorly change the alignment and I got her into a reasonable balance, at the age of 84, she was happy. The gap score really hasn't changed much. So it's really important to view things in perspective. Planning is important, but plans are useless. Scores are a guide. We've got to really individualize the surgical course to suit the patient rather than overcooking corrections. With regards to proximal junctional failure, it is nature's way of telling us that we haven't yet got it right. What we've got to think of is alignment, balance, respect for age, and definitely avoiding overcorrection. Thank you.
Sir, I think we can start the discussion. Moderators, please.
Thanks, Jwalant, for an excellent lecture. Any questions to Jwalant?
Can I take the first one? Jwalant, can you hear me? Hi, Jwalant.
Yeah, hi, Mihir. I can hear you.
I think from all the cases that we discussed, are we really correct in assuming that it's really difficult to predict what alignment the patient has been living with? Because when the patient comes to you, the patient comes with a complication, and you try to correct that complication depending on some fixed parameters in your mind. And when you do that, you actually end up overcorrecting the parameters, and that actually predisposes to the next surgery.
Absolutely. So I think a lot of what we are doing is we are chasing our own tail. If we were to think of it, pelvic incidence is one thing that we've really got to believe in. If you look at the pelvic incidence, you can roughly make out where the patient should be. And from that point, you can work backwards and say whether you want to do just a decompression or you want to fuse. If you want to fuse, then you have a friend for life, because you'll never know when you'll need to add more levels, things sink, screws pull out, etc. If you're less is more. And I've just reviewed a paper for spinal deformity yesterday where they looked at a systematic review for spondylolisthesis comparing decompression with fusion. It's an old question, but if you look at the recent papers that they have talked about in that paper, in that review, we are all going towards fusion. We want to fuse, we want to use cages. So in that kind of environment where we are fusion heavy, whether it is MIS, whether it is interbody, at the end of the day, we've got to know whether we are making a difference or not. And I think some of these parameters help. They're not the final answer, but they're a good start point. If you're obviously coming with if someone has come to you with screws pulling out, then you've got to stop, take a stock, and decide on whether the next operation is going to be the last one or not.
If anyone doesn't have one more question.
Mihir, just, there is one question from the audience, I think, Dr. Shishir Kumar. He wants to ask, this is the commonest question everybody asks to whoever has a talk on this CAP score and pelvic deformities. How does one translate the amount of kyphosis or lordosis to be kept after instrumentation on table while you're operating? How do you decide? This probably is the commonest question comes after every discussion.
So there are two things that I've said in my talk, and I wanted to pick up these because this is the common theme that happens with all of us. First is you got to work it out beforehand. And secondly, when you're operating, you have a working plan, but at the time you're putting in your screws and you're making sure that everything is fine, the screws are lining up, etc. At that time, you really can't do much because the patient is in a prone position. You can take static x-rays and measure angles, but my personal feeling is you make your plans based on the patient's age and all the other parameters. And once you have a working plan, you then focus on the patient while you're doing your operation. If you made a plan beforehand of doing a PSO, go ahead and do the PSO. I don't think any of these are going to be intraoperative decisions on should I do a PSO or not. That discussion has to be had with the patient, with the anesthetist, with the rest of the surgical team. If you're just going to be doing facetectomies, just go and do that. So there's a very well-defined continuum between making your plans based on what the patient needs, deciding what you want to do, and then doing it. So it's not an intraoperative decision, at least not for me.
I'm Kyung Cho. May I ask you, Dr. Mehta? There are many factors involved in making PJK, PJF. Do you have different risk factors between PJK, PJF? And another question is, do you think the trauma during the immediate post-op period is involved in making PJF?
Yes, I think so. And I can touch wood and say that I haven't seen one of my patients having a PJF. This lady that we saw, it was thoracolumbar junction, and that is another risk factor for stopping. I have one patient that I'm waiting to extend up into the thoracic spine. If I go into the upper thoracic spine, say T2 or thereabouts, there are 2 or 3 things that I do which I think work for us. One is that your incision can be in the midline, but you don't dissect the muscles of the midline. You go into the muscle, so you're maintaining your posterior tether and your ligaments intact. The second thing I do is I don't put in screws till the very top. I put in hooks at the very top, at the top 1 or 2 levels. The third thing, very important, is that when you're contouring your rod, you contour the rod so that it sits in the screws comfortably, and your hooks at the top end comfortably, and you're not relying on the hooks for reduction. In other words, if you have a sagittal mismatch between your rod and the shape of your spine, you're more likely that things pull out and so forth. If you really think of it, a PJK is a problem created by us. PJF definitely is a problem created by us. A little bit of PJK doesn't hurt. Many patients probably get a little bit, but that's when you look at an X-ray. It's the ones that come back to you with complaints. I see that sometimes in growing rod patients, which is not what we're talking about, so I won't go in that. But there are some groups of patients where you're more likely than not to have proximal failures. You should be able to predict them and try and avoid them. That's my feeling.
Okay, great. So if any more question, Mihir, you had some question, please.
Jwalant, in case you can avoid fixing down to the pelvis, that means you keep a mobile alpha S1 junction. Does that really change the incidence of a proximal kyphosis on top?
So I'll tell you, I've burnt my fingers I've learned the hard way. If you need to go to the pelvis, and as Ram said earlier, the lower down is not as much of a problem as higher up. So my threshold would be, if it's an adult deformity, I'm doing a big correction, etc. My feeling is go to the pelvis, get a good fix, undercorrect your lumbar lordosis, and have your adequate sagittal contour match, etc. But I think that when I've stopped short, I have had to go back in. It's very unlikely that you've kind of gone to the pelvis and you say, I wish I hadn't, especially in this age group. In fact, just recently I did one where I thought I'll stop short, very active guy, etc. And I've had to go back in and instrument his pelvis. So it's kind of fresh in my mind. And so every few years when I say that, let me try it without, I burn my fingers and then I go back and say, never again. Because in this age group, you really want to get it right first time. You have one bite of the cherry, and the more the better you do, the lesser you do, and get it right the first time, it makes life easier.
Great. So I guess in the interest of time, thank you, Dr. Jwalant, for extensive and exhaustive information about how to prevent and what to take care about PJKs. I will take this opportunity and as an honor to introduce Professor Kyun Jung Cho, who is president of Korean Spine Society and has experience of more than 30 years in the field of spine surgery. His specialization includes scoliosis and every kind of spinal disorders. The stage is yours, Professor Cho.
Okay, thank you for inviting me in this excellent meeting. I sent pre-recorded videos. Would you play that video, please? Hello, I'm Kyu Jung Cho from Inan University, Korea. It's a great honor to present my talk on this great meeting, Assicon. My topic is how to achieve optimal lumbar lordosis in adult spinal deformity. This patient had a surgery on L4-5 fusion long time ago, but the lumbar lordosis was not restored. With the adjacent segment disease, revision surgery was done, but SESTA imbalance occurred 2 years after revision surgery. For the correction of SESTA imbalance, second revision surgery with the PSO at L3 was performed. This is another patient showing Sesta imbalance 10 years after 345 fusion. With a PSO at S3, restoration of sesta balance was achieved. Hyperlordotic lumbar fusion lead to compensatory hyperextension at adjacent mobile segments, but increased mechanical load at the level and cause adjacent segment disease. Neutral sesta balance with harmonious thoracic curve and lumbar lordosis changes to positive sesta imbalance due to hyperlordotic lumbar fusion, where the compensatory mechanism hyperextending at mobile disc space can make SVA to be restored, but subsequent disc degeneration causes sesta imbalance again. So I studied, does the correction of lumbar lordosis affect restoration of sesta balance in 1 to 3 segment short fusion? And I found significant correlation between lumbar lordosis and SVA in short segment fusion. With the hyperlordotic angle cages in 2 segment T-leaf, the lumbar lordosis improved and make harmonious lumbar curvature. With one level fusion surgery can also restore sesta imbalance and make harmonious lumbar curvature. If you try to make higher collection of lumbar lordosis. For the prevention of iatrogenic flat back, restoration of lumbar lordosis is very important, even in short segment lumbar fusion. So how to achieve lumbar lordosis? Fixed sesta imbalance needs spinal osteotomy. For the flexible sesta imbalance, we can choose anterior release proceeds, including L-leaf, lateral T-leaf, or PLEF. The principle of restoring lumbar lordosis is to widen anteriorly and close posteriorly at the disc space. What you have to consider on interbody fusion using cages: cage height, cage length, cage angle, cage placement. Excessive tall cage may restrict dorsal compression, causing insufficient lordosis, or is likely to damage the end plate. So moderate height of cage is recommended. Before selecting the cage height, I measured the height with the spread several times. For the lordotic angle of cage, it's very important to achieve lumbar lordosis. So I always use 15-degree hyperlordotic angle cages. My study was, does lordotic angle of cage determine lumbar lordosis in interbody fusion? Comparing 4-degree, 8-degree, and 15-degree cages. There was a significant difference on lordosis restoration. T-leaf with the 15-degree cages showed better restoration of lumbar lordosis and prevention of loss of collection compared to 4-degree and 8-degree cages. Anterior placement compared to posterior placement offers sufficient space behind the cage for dorsal close. This X-ray shows good example of anterior placement of cage, resulting in higher correction of lumbar lordosis. This is lateral interbody fusion cases. Old ages had hyperscoliosis. With the 3-level lateral lumbar interbody fusion, good correction of adult deformity was achieved. Another case with hyposcoliosis, lateral lumbar fusion at the lumbar segment improved the deformity. For the restoration of lumbar lordosis, L-leaf is the best. Next is lateral interval fusion compared to T-leaf or PREEP. Last concern for the correction of sacral alignment is how much correction of lumbar lordosis. There is still controversy about what is the optimal correction. In my study, large collection of lumbar lordosis is needed in the patient with severe pre-op sacral imbalance and high pelvic incidence. For elderly patients with adult degenerative hyposcoliosis, L-leaf combined with lateral interval fusion was performed and achieved good correction of sacral imbalance. Another patient with good correction of lumbar lordosis. However, 3 months after surgery, PJF developed. With the reciprocal relationship between lumbar lordosis and kyphosis, junctional kyphosis develops after excessive collection of lumbar lordosis. Risk factor of PJK requiring revision surgery in this study was higher post-op lumbar lordosis and large SVA collection. So they recommend lumbar lordosis is PI -9 instead of ±9. Another study about risk factor of PJK after lateral anterior column realignment for adult spinal deformity was age, severity of ASD, and overcorrection of sacral imbalance. Ideal age-specific alignment criteria is recommended because PI increases with age. For the patient older than 74, PI minus LL is suggested 17 degrees rather than 10. I agree that it's unreasonable to assume the surgeon can make the degenerative deformed spine as good as new. So I would like to achieve physiological lordosis adjusted by age rather than ideal lordosis. 73-year-old lady showed severe lumbar kyphosis with a sacral imbalance, PI 53, lumbar lordosis, 9-degree kyphosis. With L-leaf and T-leaf and posterior fusion achieved lumbar lordosis collection, PI minus LL, 13 degree. We have to consider make harmonious curve, spinopelvic balance with the age-adjusted correction for the restoration of sacral alignment. What is the optimal correction of sacral alignment? Undercorrection is not recommended. Overcorrection is also cause PJK. So what is the optimal correction? Unfortunately, it's not determined yet. We need more study about this topic. Thank you very much for your kind attention.
Thank you, Professor Chow. I think this discussion is open for panelists. We are already running out of time, so we will make it very quick. Any comments from panelists?
I think what Dr. Cho mentioned about using those lordotic cages is very important. Most of our local companies don't provide all different angles of lordotic cages, and that becomes sometimes an intraoperative problem for us. I think we need to emphasize to our local companies to manufacture various angles of lordotic cages and make them available.
Very good. Yes, I totally agree with the idea. So the higher angle of lordotic casing is strongly recommended to achieve lordosis. Thank you very much.
Dr. Cho, I also wanted to ask you that do you, for this long segment fixations, do you do vertebroplasty in the adjacent segments to prevent failures, especially the elderly age group, which you showed?
Yes, sometimes I use KP at the adjacent segment, and sometimes you use thoracic hook. But I think to prevent PJK, PJF is not determined yet. So I don't know how to prevent PJF completely. Still needed research.
Can I ask a question to Dr. Vikas? Dr. Vikas, regarding the osteoporotic vertebral fractures, I have seen that most of the times cases that you have shown on osteoporotic vertebral fractures, not only today, is a short segment fixation using cement augmented screws. Does something like this make you think that maybe it is better to go long segment if at all you are operating? And the need for anterior column reconstruction in these patients, primarily if you are going to do it, is huge, because otherwise the implant construct is going to fail even more early. Or do you use compression at the fracture site in order to close the gap and prevent anterior failure?
Yeah, most of the times we do very well with the posterior stabilization and vertebroplasty as such. And I usually don't feel the need to compress the fracture. But sometimes if you're doing it, especially in the thoracic spine, it is difficult to achieve that in the lumbar spine, because once you compress from behind, it is likely to open up further. In thoracic spine, I feel that is one way of obviating the need of pushing cement in the fractured vertebra, where you can compress and get bone on bone contact. So that could be one good way of dealing with that. So yes, bone on bone contact would be good, especially for the thoracic spine vertebra. What was the second part of it? I didn't get that part. Sorry.
The need for anterior reconstruction.
Usually we do anterior reconstruction if we feel that there is a lot of comminution and there will be too much of stress on the implant if we just do posterior stabilization. So if there is a lot of comminution and or there is instability, we usually go ahead with the anterior corpectomy, all the way from posterior or anterior, depending on it depends upon what approach you choose. But we usually do anterior reconstruction. There are no clear-cut guidelines as such when one should do anterior corpectomy or when should one should do only vertebrectomy. I think it's all eyeballing and it all depends upon your own experience. Though there are gain scores is there which suggest that when you go anterior, when you go posterior, but more or less, I think it depends upon how you perceive the fracture, I suppose, the morphology of it.
Thank you, Vikas. A question, since we have a little bit of time, can I ask a question to Dr. Mir Bapat? Mir, there are your indications to do only vertebroplasty in an osteoporotic compression fracture versus without a neurologic deficit, or vertebroplasty plus hybrid fixation, as they call it, in these patients? When would you add implants in a patient with osteoporotic vertebral fracture?
No,
where there is no neurologic deficit?
Yeah. So basically, if you have just a compression fracture without too much of the burst component, where the settling of the vertebra is not more than 50 degrees, if you can reconstruct the height by position, you do only a vertebroplasty. In case you have a kyphosis, which is more than 15 to 20 degrees, if you have a burst and a collapse, which is more than 50%, if you have a posterior element injury, it always needs to be stabilized by a posterior construct. Further to your question, Gautam, is anterior reconstruction from end plate to end plate, or can you get away with a vertebroplasty? Now, I think we have had these discussions before. Vertebroplasty is a pain control modality. It is not a reconstruction. So vertebroplasty only controls the pain and your posterior screws only stabilize. So it is a race between your implant and your healing. If the bone doesn't heal, that implant is going to pull out. So if you need to reconstruct from end plate to end plate and achieve a good fusion, that is always a better option. But it never needs to be done if the posterior elements are stable.
Yeah.
Okay, I guess if there are no more questions, maybe we can close the session.
With this, yes, I would thank you. I thank the moderators of the session, Dr. Amol Rege, Dr. Shiva Kumar, and Dr. Neeraj Vasavda, for doing a fabulous job of moderating such a tough session of interactive case discussion and keeping it on time. I would like to thank individually each of the speakers, starting with the president of the Korean Spine Society, Dr. Cho, for his wonderful talk. My old friend, Dr. Jwalant, who has joined very fast at the middle of the night from England. Thank you, Jwalant, for that. And of course, all the panelists, starting with Dr. Vikas, Dr. Ranjit, Dr. Thomas Kishan, and then of course the case commentators, Dr. Veer Bapat, Dr. Ram Chadda, and Dr. Parasnis, for wonderful learning in this session. Thank you very much again, guys. ASSI is indebted to you. And with that, I move